Good evening. I wanted to thank everyone for joining us. Today, I'm here on behalf of our sponsor, Stefan Erickson, whose company is a distributor for Scrambler, and I'm joined by Dr. Thomas Strouse, who I will introduce shortly. I just have a few announcements to make you guys aware of. We have upcoming courses in ultrasound and pain, as well as a bunch of conferences. In New York, we're doing ultrasound training in March, the weekend of March 8th, as well as May 17th. We have ASIP coming up May 15th through 17th in Orlando. We have Aspen in Miami, July 17th to the 20th. We then have Pain Week, September 2nd through 5th in Las Vegas at the Cosmopolitan, which I will be a faculty. I'll be speaking about ultrasound guided pain procedures and regenerative medicine. And we have LAPS coming up, and it's a little far away, but it's in Chile, and you might need some time to plan this one. It's going to be well worth it, September 10th to 13th. I plan on being there, and I hope to see you there. Dr. Strouse, how are you? Welcome to the show.
Thanks so much, Dr. Rosenblum. Really a pleasure to be here. I appreciate the invitation.
So Dr. Strouse is a psychiatrist. He is faculty in UCLA, and he treats pain. He's been trained with the anesthesiologist, so he has a vast amount of knowledge as well as experience with Scrambler and other therapies to treat pain. Dr. Strouse, why don't you tell us a little bit about your background and
Thanks so much. Yeah, well, you've said most of it. So, right, my original training was in psychiatry. I've always worked sort of at the interface of psychiatry and medicine, and early in my career, had the opportunity to work full-time in a cancer center where I learned pain and symptom management from the anesthesia pain people with whom I was working, and kind of became a palliative care doc about 35 years ago. So I've brought that forward and had the privilege of working on a test writing committee with Tom Smith, who I'll refer to a few times, really one of the leaders in Scrambler in the United States. Tom's an oncologist and palliative medicine doc. And he introduced me to this thing called Scrambler during the breaks in our committee meetings. He's about the smartest guy I know. So I thought I needed to take it seriously. And about 5 years ago, we began our program, and I'll be talking about that tonight.
Yeah, I mean, I mentioned in the other podcast, my experience with Scrambler was very brief. About 15, 16 years ago, a CRPS patient mentioned it to me. I had no idea what she was talking about.
Well, I'm gonna proceed as if you can all hear me. At least I lost Dr. Rosenblum on the feed. I'm not sure what that's about, but maybe I'll just launch into my talk with the hope that he can rejoin us. I see that there are still 14 participants, so I will just move forward and hopefully he'll be back. Good, and I hope you can see
me out. Sorry.
Oh, good. Okay, you're back. Well, I was getting anxious.
Yes. Go ahead, please.
Okay, sure. So I'll just begin my talk. Let me jump back into SlideShare mode and to my presentation format. Here we go. So I have nothing to disclose. Although the folks at Scrambler, Stefan Erickson, are sponsoring this, I'm not being compensated for my time and effort. I do want to thank Tom Smith at Hopkins and also the inventor of Scrambler, Professor Giuseppe Marineo, who is in Rome, for bringing this extraordinary modality to us. This group does not need me to remind you that there are a number of neuromodulation techniques in which Dr. Rosenblum is an expert. I've tried to summarize some of them here, and as a psychiatrist who is not trained to do interventional work, I'm just going to point out that the non-invasive ones are the ones that I'm going to emphasize. And in particular, Scrambler, down at the bottom, and peripheral magnetic nerve stimulation are both of great interest to us here. Just a sort of nice picture, another way of thinking about these ways of helping with nerve pain. And importantly, as recently as 2021, Scrambler was not included in this otherwise nice review that was in the Lancet. However, that I think began to change in July of 2023 when Dr. Smith and Charles Laprinzi from Mayo published a very nice review article in the New England Journal on cutaneous electroanalgesia for the relief of chronic and neuropathic pain. Primarily, this review compared Scrambler with TENS, which, although metaphorically, the devices look similar, that is boxes with wires that connect a patient's skin through sticky electrodes. In terms of the waveform and signal and sort of conceptual design, and perhaps most importantly for patients, the durability of the effect, they're quite different. In particular, when Scrambler is working, Scrambler actually, over a course of 5 to 10 treatment sessions, provides an analgesic benefit for nerve pain that is durable, that is, that lasts for weeks or months or longer. I'm going to present to you some of our chemotherapy neuropathy data that I hope will help you understand that a bit more. And you've all, again, as pain docs, you've all seen versions of this diagram. I'm simply showing it to emphasize that primarily we're talking about pain associated with injury in one form or another to the nervous system, whether that's a central injury like stroke or demyelination like MS or neuromyelitis optica spectrum disorders, or whether it's peripheral like what happens with chemotherapy or diabetes. So this is the Scrambler device. This is actually not the most current one. This is, I think, the previous generation. As you can see, it has 5 channels on it. In the lower part, you get a look at somebody who's getting treated for both a sort of a stocking glove neuropathic pain condition with hands and feet, each getting a couple channels. We'll talk more about that in a bit. What is actually going on with Scrambler therapy? So Marineo says that the device functions like an artificial neuron, and his assertion is that the sequence of stimuli that the device generates simulate non-pain or normal somatosensory input, such that if you have functioning sensory nerves in the skin to which the sticky electrodes are attached, they transduce that signal to larger structures, eventually to the dorsal horn of the cord and to the brain. And indeed, there are some studies that I will show you a glimpse of later on that demonstrate central correlates of this peripheral stimulation. As Marineo begins to speak about the technology, my non-electrophysiology, non-engineering background comes through, and I really don't understand most of what he says, but you can study these slides or the New England Journal article for that matter if you're interested more in the details. I think the important point, and this is lifted from the review, is that the waveform for Scrambler, this sort of sawtooth or shark's fin waveform, is quite different than the square waveform that you see with TENS in its various permutations. And Marineo asserts that's an important part of the differential effect. Again, more details here, perhaps more than you care to know. Very low current intensity, never more than 5.5 milliamps, much less than an off-the-shelf TENS unit, in case that's of importance. So again, we've already talked about this. That is that the sticky electrodes capture surface receptors. Marineo asserts predominantly C fibers, as opposed to the A beta and A delta fibers that TENS is alleged to or believed to activate. And again, his assertion is that we're not talking about the gate control theory, but a very different approach to obtaining and maintaining analgesia. And the reason that the Netter dermatome chart is in the middle is because we typically do use a dermatomally informed strategy to place electrodes. So for example, with a patient with chemoneuropathy mainly affecting toes, we're really talking mainly about L4, L5, and S1. For hands, we're talking about mainly C6, C7, C8. More on that to follow. As I mentioned, the device was initially designed as a treatment for chemotherapy-induced peripheral neuropathy, which for those of you who see it in your practice know it's a nasty one. Particularly the taxanes and the platinums can induce a exquisitely painful burning and tingling and numbness. This work was done by Tom when he was still at Virginia Commonwealth, published early on in the trajectory, about a year after the device was FDA cleared in the United States, showing, as you can see, pretty dramatic decreases, about 60% reduction in pain scores over a course of 10 treatment settings on 10 consecutive days, patients going from roughly a 6 to roughly a 2.5. Of course, we know that if duloxetine or gabapentin performed like that, their FDA approvals would have been much simpler and much more rapid, and we wouldn't have numbers needed to treat of 6 to 9 patients to get a benefit. This is really notably superior, although there are no head-to-head trials, I should say. Similar data from Mayo, published about 5 years later. This is actually cancer pain, not neuropathic pain data. This is a case example of somebody with cisplatin-induced CIPN who was out about 4 years from his treatment. and you can see the electrode pairs roughly on L5 and S1 on the lower extremities with a dramatic decrease in pain. As a quick aside, Marineo believes that Scrambler is most effective for people who have fixed static nerve injury, like somebody who is exposed at some remote time in the past to a neurotoxic chemotherapy, but who isn't still seeing it. The rule of thumb in the field is somebody needs to be at least 2 or 3 months out from exposure to cytotoxic chemotherapy, because otherwise they're still having, theoretically at least, acute nerve injury that may have an adverse effect on the durability of the benefit. On the other hand, I will say that I see lots of folks who are on chronic immunotherapies, various MABs that themselves can cause peripheral neuropathy. Some of those people are going to have to be on those drugs for the rest of their lives because they are in a chronic illness mode of treatment. And we treat them, and they appear to benefit as well. So this is more from Mayo on chemotherapy neuropathy. And in this study, they looked not just at burning, tingling, but also at numbness. And this was comparing an active placebo or an active control, which was TENS, against Scrambler, showing about twice the efficacy of Scrambler compared to TENS. This is some of our data. Actually, this is our first 60 chemotherapy neuropathy patients at UCLA over the last couple of years. Again, you can see roughly 9 treatments. These are pre and post treatment, just visual analog scale pain ratings. Pretty dramatic benefits. And to boil that down a bit more, the sort of global improvement, are you better, worse, or the same? About 80% of people report better after a course of Scrambler. Something like 77% of those 83 had 50% or more improvements in their pain. Another 6% had greater than 30 but less than 50. And as you can see, about 15 or 18% of people are non-responders, and we have no capacity ahead of time to predict who's going to be a non-responder.
I'm sorry
Yes?
if you said it. I'm sorry if you said it already.
No, please.
Over what course of duration did they get the Scrambler for?
Yeah, so the optimal model is 10 treatments over 10 days, so 2 5-day weeks consecutively if it can be pulled off.
Okay.
Yeah.
Thank you.
Yeah, sure. As an aside, some people need fewer than 10. The definition, according to Marineo, of a completed course is either 10 sessions or when your pain goes to 0 and stays there for more than 24 hours. We've had a chemotherapy patient who did that with one treatment session, but the majority between 5 and 10. And some go longer. If they're still getting benefit after 10 with each session, some elect to go longer.
Right.
But although the volume of data is not as impressive, certainly Scrambler has been employed for other horrible chronic pain syndromes. This is a CRPS patient. Many of you, of course, are very familiar with this life-changing problem. And we've had a lot of success with CRPS patients with Scrambler. So I would say that that's another use worth considering. A variety of other less well understood peripheral neuropathies, like small fiber neuropathy, also appears to be Scrambler responsive, although the anecdotal belief among those who do a lot of this is perhaps small fiber neuropathy, which presumably is autoimmune mediated and presumably is associated with continuing or progressive injury, may be thorny or less responsive than chemotherapy neuropathy. That's been my experience as well. This is another CRPS patient who had a dramatic benefit. Again, you can see this is actually this panel on the right of this slide gives you a sense of how we place electrodes. You typically don't put them over the painful area. So each circuit, each electrode pair has got a black and a colored electrode. The convention is that the black electrodes go closest to the spinal cord, and the corresponding colored or landing electrode, and you can see these are different colors, yellow, white, and blue, are more distal. In this case, these are placed along C6, C7, C8 just above the elbow and in the forearm, not on, but just a little bit proximal to the most painful area, which in this patient was the dorsum of the hand. And it's really quite extraordinary to see the burning, tingling, allodynia, and sometimes temperature and color asymmetry melt away during the course of treatment, kind of like what you see when you have a successful lumbar sympathetic block. Scrambler is extraordinarily safe, and as we think about where it might fit in for patients who are reluctant to consider an interventional procedure, it's certainly reasonable to think about Scrambler as something to try first. In this naturalistic study of 1,150 patients, really the only The only consequences were a small hematoma under the sticky electrode in an anticoagulated patient and some red irritated patches in somebody who might have been a little allergic to the adhesive. There are in the label, in the FDA indication, language that says you should not treat somebody with a pacer, an implanted cardiac pacer, or other electronic device. We could talk about that if you guys want to, but that is in the manual, and presumably that's because there's concern that the pacer or the pump could pick up signals from the scrambler and function aberrantly. And of course, you're the experts in knowing about potential complications of either peripheral nerve stimulators or spinal cord stimulators with lead migration or fracture, or on the rare occasion, some infection. Again, no surprise to this group, but there are CNS correlates to successful peripheral neuromodulation. This is a study, as you can see, from 2022, looking at pre and post successful Scrambler treatment in patients who I think had burns. Yeah, showing activation of, I should say decreased cerebral blood flow in pain centers after a Scrambler session that was associated with achieving analgesia. Sorry, yes. Sorry, comment?
Yeah, that's impressive. How long does the therapy last?
So a typical session is 35 minutes. I'm sorry, I should have said that earlier. You as the operator can select the duration of treatment session. Whatever number of minutes you select, the device automatically divides it evenly into 4, and each program course is essentially 4 repetitions of this sequence of signals that are part of the proprietary design. We've landed at 35 because that allows us to have reasonable throughput. We might treat as many as 10 patients on a busy morning. We have 2 machines, and that allows us to turn the room roughly every 45 minutes or an hour.
And how long does the therapy last for the patient, though?
Right. So variable from person to person, very difficult to predict, but my sense now, again, 2,000 or 2,500 treatments in, is if the person has a fixed injury that is not subject to ongoing inflammatory or metabolic insult, that the results often last months or longer, and that in somebody, let's say with diabetic neuropathy, where presumably there's continuing metabolic injury, even with somebody with really well-controlled A1C, glucose, et cetera, a less of an effect, less durable. I wish I had a better answer for you than that.
Okay.
We've treated a number of people with bad post-herpetic neuropathy with really nice results. Typically, the electrodes are placed dermatomally just above and just below the affected root or roots. Again, some people with years of pain who've had a really great benefit. Hopkins has actually published a really nice paper a few years ago. They have a big NMOSD center that used to be called Devick's disease. It's now called neuromyelitis optica spectrum disorder. I didn't know what this was until I started scrambling. This is a horrible autoimmune demyelinating process of the spinal cord, which often presents with blindness. And even in patients who don't get blindness, they can have both motor and severe pains syndromes. Again, this is a dermatomal strategy for this gentleman with severe pain in his left arm and shoulder. And we are actually just treating our very first NMOSD patient who's had a dramatic benefit.
Nice.
Sorry. Yes, please, Dr. Rosenblum, another comment.
No, I said nice. I said that's great. Fantastic.
I should tell you that the product packet also says do not put Scrambler electrodes on the neck or face, but we do it all the time. This is somebody with trigeminal neuralgia, and we probably have treated now 20 or 25 folks with trigeminal neuralgia with varying degrees of success. This is somebody with post-stroke pain. We've had a number of patients who had shingles or just who have primary functional trigeminal neuralgia who've gotten some nice benefits. This is, as you can see, this is post-shingles pain in V1, somebody who responded really nicely. This is a Tom Smith slide, by the way. Wow, I seem to be having blasted through these. So we are happy to evaluate patients. We've had patients come from as far away as DC and overseas. There are Scrambler operators around the country, but not that many, predominantly related to problems with how to get paid for doing this work. But I'm going to stop talking and stop sharing and see if people have questions or comments.
Yeah, guys, feel free to ask him questions. I guess the first question we all want to know is it's covered? Is this covered? Are we going to get paid?
Right. So, when the AMA assigned the procedure code to Scrambler in 2009 or 2010, after the FDA's initial clearance of the device as safe, the AMA assigned a procedure code that you may all be familiar with. It has a capital T on the end, which stands for temporary. And as I understand it, although I'm not an expert in this, that is a signal to both CMS and the commercial insurers that they don't need to pay for this. So it's very difficult to get paid by insurance companies for Scrambler. Most of the operators that I am aware of do this as a cash business, which unfortunately limits who can get it.
Right. And I'm sorry if you mentioned, is there a type of patient that responds best to the scrambler therapy?
So I think the data is best, and our experience with those CIPN patients confirms that CIPN appears to be exquisitely responsive to Scrambler, and that by far the most number of clinical trials, both just naturalistic and either active placebo or sham controlled trials, support that. These other indications of various nerve pain syndromes are less well supported, although there are many case series out there, including the NMOSD case series that I just showed you from Hopkins, and post-herpetic neuralgia case series that Tom Smith and others published. And again, there are many nerve pain syndromes where they're just so rare that there aren't large numbers, but where we've seen benefit.
No, it sounds great. I mean, well, it looks like we have a question here. Hold on. A few questions. All right, the first one is, what is the cost of the device? Now, if you don't know the answer, I could ask Stefan to chime in.
Let's let Stefan answer, because I think that may have changed some in recent.
Let me see if I can, Stefan, if you want to talk now, if you're available to talk, I can unmute you. And it looks like you raised your hand. All right, you should be able to talk, Stefan.
All right. Hi, can you hear me?
Yep. All
Hi,
right.
Stefan.
Like my video's turned off. Yeah, so cost of a device, if you're a medical provider, the price is for purchasing the device itself, or if you're interested in doing more of a variable cost, we do have a placement agreement program where we do a per treatment fee. So you've got one of two options: either buy it outright, or you can just look for a variable cost of a per treatment fee on the back end. And then there is a training fee associated with it. So,
And then they're paying per treatment, correct? There's like there's a one-time setup fee and they pay every treatment basically?
correct. If they decide to go with the placement agreement program, then the cost of the device is zero up front, and then it's just a per treatment fee on the back end.
Gotcha.
Yep.
Another question relates to what I guess is for you, Dr. Strouse. What do you do about patients on anticoagulants?
Yeah, so I think it's a non-issue. As I hope you've gotten a feel for the kinds of folks we are seeing. Many people who are getting active anti-cancer treatment, many of whom are anticoagulated, folks with other kinds of chronic medical illnesses. And other than the needing to be careful about pulling sticky electrodes off skin because of the possibility of just bruising or bleeding, I don't think there are other concerns that I'm aware of or that we've seen.
You mentioned in one of your slides, but a patient with sciatica, but there's a question from one of the docs about if the patient has radicular pain. What's your experience with that overall?
Yeah, our experience with radicular pain is mixed. And I'm not sure how to understand that, other than many people with radicular pain, of course, have an ongoing source of root compression or irritation, some anatomic thing, foraminal narrowing,
Sure.
etc. So again, when there's a persistent tissue generator, an ongoing source of nerve injury, my sense is in general that may reduce the responsiveness, but we've had some folks get a really great response.
Another question is, what is the average cost per treatment on the market?
So I can only tell you in LA, which is where I've sort of informally sampled, and I would say it's between 250 and 350 bucks per session.
Got it. And you
Which is a
mentioned
bargain, by the way, in terms of the amount of physician time and tech time and room time.
Sure. So basically the workflow is they basically come in, maybe you do vitals, maybe you don't. You just slap on the stickers. turn up the volume and just walk out, or is there somebody babysitting the patient?
No,
Like,
no, that's right. We typically do the initial consults via Zoom. Almost everybody we've seen has already got a long history as a pain patient, so we pretty carefully review both the imaging and the procedure uh, descriptions that they've had, and obviously their meds. Um, make sure there are no contraindications like a pacer or anything like that. The first day, yeah, they come in. We may be meeting them in person for the first time. Then we probably examine them briefly in terms of the painful area. They sit in what looks like a dentist chair that has a foot, an electric foot pedal, and so they can recline comfortably. We kind of figure out, often we figured out even before we see them, what dermal approach we want to, dermatomal approach we want to take. We put on the electrodes, we start the device, we adjust the intensity of stimulation. It isn't just you turn it on, you leave. Probably every 8 or 10 minutes, either I or the technician is going back into the room, A, to check to see that the patient's comfortable, B, to monitor their response, because we frequently see the analgesic response beginning 5 or 10 minutes into a 35-minute session, and C, to adjust intensity, because the goal, what I haven't said yet, is that we're trying for a treatment intensity that just approaches where the patient would say, this is not tolerable anymore, you got to stop. So that, and people, of course, accommodate to the stimulation over the course of a 35-minute session. So we do adjust.
so I mean, I do a lot of PNS, so we're telling the patient, tell us if you have pain, pressure, paresthesia, pain. Are you looking for paresthesia, pressure, pain? What exactly are you looking for when you
Sorry,
turn up?
sorry, I wasn't clear about that. So we're looking for sensation under the electrodes, and typically what patients experience is sort of like fire ants or a burning or scratching sensation. As the device goes through that cycle, that can change to a hum or a tap or a snap. But it should never be painful. We're not looking for a paresthesia down the dermatomal route. We're looking for sensation under the EKG pad, under the sticky electrode, and analgesia.
Got it. And in terms of, I mean, if you don't know it offhand, I'm just curious, what are we talking, milliamps or volts? Like how's it?
So the maximum milliamperage output is about 5.5, 5.5. That's the maximum output of the device, which is about, a 20th, a 10th to a 20th of what a TENS unit produces. So the idea that should distract a pacemaker or make a defibrillator fire or confuse the sensory apparatus in a pacemaker seems pretty unlikely. But that is, again, what the materials in the label say, that we shouldn't
Got
do
it.
it.
Nice. So anybody else have any questions? I mean, we have an expert here, and I wish I was, because this sounds like a great therapy. In terms of, I guess, the economics, I guess, Stefan, it really would come down to more what they make, how much their patients are willing to pay versus your overhead, the charge of the service. And I guess you could talk to them privately after the webinar if they're interested. I'll have your link on the show notes and everything. But
Sure, Rosenblum, sorry, I don't mean to interrupt,
please,
but I
no,
just
please
wanted to say,
interrupt.
one of your listeners called the question that I was avoiding answering, and that question is,
Oh,
have we ever done this in a patient with a pacemaker? And since the question was asked, I will answer. The answer is yes. Because we're on a university campus, we have the wonderful resource of a cardiac electrophysiology fellowship just across the street from us. We have the device rep, after extensive informed consent. We have the device rep and the EP fellow come and monitor the patient during the first session. We put a donut over the defibrillator if there's a defibrillator. We've never had a problem, and we've probably done it 5 or 6 times. But that's off label, and your risk manager will tell you don't do that. We have chosen to do it because we see ourselves as sort of a venue of last resort for desperate patients with really bad problems.
got it. And now they're asking about discogenic back pain and the experience.
Yeah, I think I would answer similarly to radicular pain, which is if there's something crunching a nerve root, I think that makes it a lot harder to get an effect that lasts, although people can get an acute analgesic response.
Got it. So we mentioned already the cost to the patient that you said was about 250 to 350.
Yes.
Okay, maybe you mean the overhead, which I'll let Stefan answer. I don't know if he wants to answer it here because it might change from location to location, right? But Stefan, if you want to chime in, feel free. If not, you can talk privately to everybody.
Yeah, I think if some providers have some questions on the pricing, then why don't they reach out and we'll kind of walk through the information, and we can kind of share what the pricing looks like and make sure it's going to be financially feasible for them.
Thank you.
There's
So-
one other question in the chat about peripheral neuropathy, and again, I hope I addressed in my comments and with my slides. That's really what the device was invented for. Initially chemotherapy peripheral neuropathy, but it seems to be effective for other kinds of peripheral neuropathies as well. So I hope that's helpful to the person who posed the question.
And there's another question about, have you had patients complete the treatment with great results and then come back with back pain?
Yes, and then come back with
I'm sorry,
pain.
with
Yeah.
pain. Come
So,
back with pain.
yes.
Excuse me.
So
Long day.
we have had some relapsers, there's no question. Some of those people have had pain return within a few weeks. Some of those people have come back 6 months or a year later. The assertion in the Scrambler received wisdom is that booster sessions of 1 to 3 treatments will typically regain the benefits that the initial course of 10 accomplished. I think that's about right. But some people like us so much that they insist on coming back for a full course of 10.
I have a question. What
Please.
about the failed back patients? Because these are like, in a way, they're like the neuropathy patients, because it's
Yes.
like they're so hard to get under control sometimes.
Yes. Yes.
So
We've
more
had
reaction or radicular symptoms, or both?
or both. We've had a few wonderful gains and a number of catastrophic failures, or I should say lack of benefit. We've never made anybody worse. We've had some people who I sure were not going to get better, morbidly obese, multi-level, disc disease, multiple surgeries, lots of hardware. We've had a few people who've just thought this was the best thing in the world and developed such a positive association being scrambled that they would get into the chair and immediately fall asleep and wake up 35 minutes later pain-free. I don't know what that was about, but it does happen. But I'm cautious about the failed back patients because I know how complex they are and how intractable their pain is.
Sure. Looks like they like your slides. Somebody's requesting them.
Oh, sure. Yeah. Let me give you actually. Oh, can you see my slides still? Let me just ask that person to send me an email. Let me reshare it because I think I'm not sharing, and I would be happy to.
And Dr. Strouse, if it makes it easy, this is Stefan, you could send them to me and I could actually get them posted. And so those
Okay.
who attended, we could just send out a link to everyone so that you just don't get bombarded with emails.
Yeah, that's fine. Actually, I think I probably need to get Dr. Smith's permission to share his slides, and many of these are his. So that's why I'm being a little cautious.
This is going to be on my YouTube channel as well as the PainExam podcast audio for this. So
Okay.
you guys could see it there. It'll be
great.
on YouTube or on my website. So you can always press pause and look at the slides. So anyway, are there any questions before we wrap it up, guys? Anything else? Oh, you're welcome. Okay, so I wanted to thank you, Dr. Strouse and Stefan, for helping me organize all this. I learned a lot. I'm very interested. I hope you guys are as well. I mean, this is fantastic because these people are desperate. Neuropathy people are desperate, failed backs, people in pain. So I think it's really great that you did this, that you do this. Any closing remarks?
Just that you have extraordinary resources and skills with Scrambler in the Northeastern United States and in Southeastern United States. Dr. Stephen D'Amato, D''Amato, is down in Florida and probably has done more Scrambler than anybody in North America. The folks at Hopkins are very busy. Dr. Smith is in the process of retiring, so I can't necessarily tell you he'd be available to your patients. I'm pretty sure there's Scrambler providers in the greater New York City area. And then there's lots of flyover states where there's no Scrambler whatsoever. So, but I'm happy to be a resource. And actually, Stefan knows exactly where everybody is and has a map of the country that he could share with you.
Sounds like it's probably less than 50 practitioners in the States or something like that, I would imagine.
Yeah,
Stefan,
we've got a little
you know
over
the number. Yeah,
we've got a little over 100 providers now, East Coast to West Coast. So if you look at the map, if you zoom out, it looks like it's got pretty good coverage across the U.S. But when you zoom in, you'll see that there's definitely opportunity in many cities that there's and a lot of vacancy. So there's definitely an opportunity to really expand this and grow this and really start treating all those patients with neuropathic pain.
That's amazing. Thank you. Lastly, I want to tell you guys, if you didn't catch the last webinar, on the intranasal ketamine. Check it out. And I have one coming up where I'm doing cervical ultrasound. So I hope you guys could join me. It's February 25th, sponsored by Claris. I want to thank everybody for being here tonight, especially you, Dr. Strouse and Stefan. I want to thank everybody at home and wish you all a good evening. And
Thanks so much.
hear from you guys soon. My pleasure.
Pleasure.
Thank you.
Good night.
Bye.